Bismillahirrahmanirrahim. Assalamu alaikum and very good morning, ladies and gentlemen. I am Dr. Shan-e-Rauf. I'm consultant hematologist from AFPMTC. On behalf of Chairperson Organizing Committee HAEMCON2021, Brigadier Retired Nuzhat Mushahid, and President Pakistan Society of Haematology, Professor Dr. Major General Parvez Ahmed, I would like to welcome our panelist and speaker to this session. I'm the moderator. It's our pleasure that today in this session we have esteemed panelists. That is, the panelist comprises Professor Dr. Nadeem Ikram, Professor Dr. Lubna Zafar, and Professor Dr. Ayishah Choudhary. I welcome you all, sir. Ma'am, I welcome you. And before we start with our session, I would like to just very briefly narrate the rules of the game. That this session comprises 130 minutes, and we have a total number of 10 speakers in this session, and each speaker has 10 minutes. So I would request all the speakers to limit their presentation to 10 minutes so that we are in time. So with this, I would start with the formally opening of this session. Our first speaker is Dr. Murad Ali from Armed Forces Bone Marrow Transplant Center. He is FCPS resident in clinical hematology, and his topic is incidence and risk factors for oral mucositis following hematopoietic stem cell transplant. Over to you, Dr. Murad.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. I am Dr. Murad Ali, resident clinical hematology, Armed Forces Bone Marrow Transplant Center, and today I am going to present the data on incidence and risk factor for oral mucositis in post-hematopoietic stem cell transplant patients. Hematopoietic stem cell transplantation is potentially curative treatment for a number of benign and malignant hematological disorders. And oral mucositis is a serious complication affecting both allogenic and autologous transplant, causing significant morbidity. Reported incidence is from 60 to 90%, and risk factor includes myeloablative conditioning, prior irradiation, methotrexate for GVHD prophylaxis. Objective of the study is to determine the incidence and risk factor of oral mucositis in patients undergoing hematopoietic stem cell transplantation. Study design was retrospective observational study conducted at Armed Forces Bone Marrow Transplant Center from December 2019 to December 2020. Both gender and all groups were included in the study undergoing bone marrow transplant, whether allo or auto. Patients undergoing second transplant were excluded from the study. Total cases were 47. Variables were age, gender, body surface area, disease, conditioning regimen, previous irradiation, methotrexate prophylaxis, incidence and severity of mucositis. Data. Mucositis was graded as grade 1 to 4 as per WHO mucositis criteria, and requirement for analgesia, whether opioid versus non-opioid, was also documented. Results. In the study, 70% of the patients were male, while the remaining 30% were female. Median age was 11 years. Transplant types and underlying condition. 17% of patients underwent auto-BMT, while the remaining 83% of patients underwent allo-BMT. Total cases of beta thalassemia were 18. 6 cases were of aplastic anemia, and the remaining were of acute leukemia, ALL and AML. And 8 cases were of multiple myeloma. In 47 patients, about 79% of the patient had the incidence of oral mucositis, while 21% had no mucositis. 16% of the patient experienced grade 1 mucositis, 32% of the patient had grade 2 mucositis, while 43% of the patient had grade 3 mucositis, while only 8% of the patients had grade 4 mucositis. Median time to symptoms onset was day plus 8 post bone marrow transplant. About 80% of the patients required opioid analgesia, while 21% of the patients were managed conservatively. Median time to symptoms resolution, it was 8 days. The data show there was significant, the incidence of oral mucositis was significantly low in patients with aplastic anemia as compared to multiple myeloma, acute leukemia, and beta thalassemia. Risk factor for mucositis. Those patients who received myeloablative condition, they experienced more oral mucositis, about 84% in this study, as compared to those patients who received non-myeloablative conditioning. Those patients who received prior irradiation for different disease, particularly in acute lymphocytic leukemia, the incidence was 100% as compared to those patients who did not receive any radiation. Those patients who received methotrexate as part of GVHD prophylaxis, they experienced 90% oral mucositis as compared to those patients who did not receive methotrexate as a part of GVHD prophylaxis. There was no significant difference in the incidence of mucositis in relation to age of the patient, gender, CD34 count, and TNC rows. A study done in Iran showed the incidence of mucositis at 60.7%. Gender and prophylaxis medication were found to be only predictor of mucositis. L. Vigliano et al. Reported increased incidence of mucositis in children, while J. and Reddy found significantly increased incidence in patients who received MTX for GVHD prophylaxis. Conclusion. The incidence of oral mucositis is significantly higher in patients who received myeloablative conditioning, including high-dose melphalan for autotransplant, compared to non-myeloablative conditioning. In the study, it was 84% versus 20%. 84% of the patients who received myeloablative condition, they experienced oral mucositis. History of prior irradiation and use of MTX as part of GVHD prophylaxis are also associated with increased risk of oral mucositis. Thank you.
Thank you, Dr. Murad Ali. With this, our next speaker is Dr. Naureen Jalbani from Liaquat University of Medical and Health Sciences, and her topic is impact of routine immunization on outcome of COVID-19 patients and their hemogram findings. Over to you, Dr. Naureen.
Assalamu alaikum. My name is Dr. Naureen Jalbani. Today the topic of my presentation is impact of routine immunization on outcome of COVID-19 patients and their hemogram findings. I have no conflicts of interest. Introduction. Coronavirus 2019, COVID-19 has become a global pandemic currently affecting 215 countries and regions. COVID-19 severity and mortality are higher in elderly patients with pre-existing chronic diseases. Children seems to be less susceptible to COVID-19 than adults. Looking at the outcome of pediatric patients, it was likely due to routine vaccinations. Countries without universal policies of BCG vaccination, such as Italy, Netherlands, and USA, have been more severely affected with the COVID-19 compared to countries with a universal and long-standing BCG policies. BCG vaccine induces the expression of genes that are involved in the antiviral innate immune response against the viral infection with long-term maintenance of BCG vaccine-induced cellular immunity. Other vaccines such as hepatitis B vaccine, polio vaccine, measles, mumps, rubella have also hints in observational studies that they could provide some protection. This is the graphical representation of how come a BCG can cause the lowering of the viral burden in a way that basically it causes activation of cytotoxic T cells, which lowers the viral burden. It induces the activation of IFN alpha, complement C3 and B cells, and certain chemokines that causes decrease in the viral burden, and releases the interleukin 4 and interleukin 10 that causes decrease in the hyperinflammatory response and the cytokine storm that is basically induced by the COVID-19 cells. Objectives of my study are to determine the impact of vaccinated and non-vaccinated COVID-19 patients over their clinical condition and to assess their changes in hemogram. Material and methods. Study design was descriptive cross-sectional study. Study setting was Civil Hospital, Hyderabad, LUMS. Duration of my study was October 2020 to December 2020. Sample size was 40 adult patients. Sample selection. Inclusion criteria: patients with a positive PCR report for COVID-19 and patients who had symptoms and were hospitalized were included in the study. Exclusion criteria: asymptomatic patients were excluded from the study, and patients with a known comorbids such as hypertension, diabetes, and liver disease were excluded from the study. Data collection procedure: a proper history was taken regarding the immunization and examination for the BCG mark. Venous blood sample in EDTA tube was collected. It was processed in Sysmex XN 1000 Japan for CBC, and a proper follow-up of patients to know their hospital stay and oxygen dependence was carried out. Now the results. According to demographic data, most of the patients were male, that constitute 62% of the cases, and the rest of 38 were females. Mean age was 28.6. Age range was 18 to 50 years. Results. Among 40 patients, 65% patients said they were properly immunized, while 35% said they were not immunized properly. Hospital stay and oxygen dependence: among immunized patients, 67% patients had less than 1 week of hospital stay and were not on oxygen support, and 33% were continuously on oxygen support and had more than 1 week of hospital stay. Non-immunized patients were 35%. All had hospital stay of more than 1 week and were continuously on oxygen support. According to the hemogram findings, HB mean was 10.8. It was less than 8 in 17.5% cases, and it was more than 8 in 82.5% cases. Lymphocyte count mean was 3.6. It was less than 2 in 35% cases and more than 2 in 65% cases. Platelets mean was 226.5, less than 50 in 22.5% cases and more than 50 in 77.5% cases. Discussion: in our study, a positive impact of routine immunization was found. TM Wassenaar et al. Made clinical trials to assess if the BCG vaccine can act as a prophylactic or ameliorate the disease, and they can conclude that there is currently no compelling evidence of any such protective effect. Ines Christensen et al. Stated that measles BCG vaccine may have a beneficial effect on COVID-19 in addition to protection against measles and tuberculosis. Eleanor M. Rees et al. Stated median hospital stay ranged from 4 to 53 days within China and 4 to 21 days outside of China across 45 studies. In our study, it was less than 1 week in the case of immunized patients. Mihai G. Nitia et al. Concluded that increased susceptibility to severe disease in the elderly and elderly individuals with no comorbidities argues for an initial defect in the antiviral host defense mechanisms. Long-term boosting of innate immune responses, also termed as trained immunity by certain live vaccines such as BCG, oral polio vaccine, and measles, induces a heterologous protection against the infections through epigenetic, transcriptional, and functional reprogramming of the innate immune cells. This study suggests that the conclusion of my study was that the routine vaccinations have a significant role on the outcome of patients with COVID-19. Properly vaccinated patients were less likely to develop complications and a faster recovery compared to those who were not vaccinated. Acknowledgements. I am grateful to the laboratory staff and all patients. Way forward, this study is among the only few attempts to identify the impact of routine immunizations over the COVID-19 outcome. Recommendations. As the extent of this research was limited to a single center, a similar research can be carried out in the larger sample of participants. Thank you.
Thank you, Dr. Naureen. Our next speaker is Dr. Ayishah Choudhary. She is MPhil Hematology and currently working as Assistant Professor of Pathology in University of Lahore. And her topic is Polymorphism of Fibrinogen Gene in Obese and Non-obese Children. Over to you, Dr. Ayishah.
Bismillahirrahmanirrahim. I am Dr. Ayishah Choudhary from University of Health Sciences, Lahore. The topic of my study is the RS180070 and RS2070011 polymorphism of fibrinogen in obese and non-obese children. Well, the childhood obesity is one of the most prevalent nutritional disorders. Childhood obesity is classified according to BMI percentiles, considering the greater than 95th percentile as obese. Well, about the prevalence of childhood obesity, according to CDC, about 43 million children are overweight or obese worldwide. In obesity, there is the increased production of interleukin-6 by the macrophages of adipose tissues that are considered to be responsible for the increased fibrinogen levels. The fibrinogen gene locus comprises the three genes codings, that is fibrinogen gamma, fibrinogen alpha, and fibrinogen beta. All are clustered in a region of 50 kb on the long arm of chromosome number 4. The objectives of our study were to determine the fibrinogen in obese and non-obese children, to determine the RS070 and RS011 polymorphism in obese and non-obese children, and also to calculate the allele frequency of both polymorphism in our local population. It was a cross-sectional comparative study which was conducted at Department of Haematology and Department of Human Genetics, UHS. 40 obese and non-obese children were included in the study according to age and gender matched. Children having any genetic disorders, endocrine disorders, hypothalamic disorders, and taking medications were excluded from the study. Analog physician scales, health scales, were used to measure the height and weight, while the waist and hip circumference are measured by using the measuring tape. The fibrinogen levels were determined by using the Claus technique on coagulation automated analyzer, while the both polymorphisms are analyzed by using the PCR RFLP technique. Coming towards the results, on comparison of anthropometric characteristics of the patients, both controls and obese children, the weight, BMI, and waist and hip circumference are found to be significantly increased. In hemostatic parameters, the fibrinogen level is found to be significantly increased. In comparison of A/G allele frequency in obese and non-obese children, the G allele is found to be significant in obese children with a p-value of less than 0.001. On comparison of allele C/T frequency in obese and non-obese children, we found the C allele to be increased significantly in obese children with a p-value of less than 0.001. The RS180070 genotype prevalence found in our population, it was found that Heterozygous CT is found to be significantly increased in non-obese children. But the CC is also found to be significantly increased in non-obese children. Well, about the prevalence of RS2070011 genotype, it was found the heterozygous AG is found significantly increased in 20 with the number of 23 with 40.1% with p-value of 0.001 in our population. By using the Pearson correlation, it is found a positive correlation between the BMI and the level of fibrinogen. When BMI served as a dependent variable in the multivariate regression analysis, fibrinogen showed a strong interdependence with BMI. It was also determined that BMI, waist hip ratio, and fibrinogen were predictor variables explaining the significant proportion of variance in RS180070. Well, overall prevalence of overweight and obesity has significantly increased. In childhood obesity, there is increased risk of arterial thrombosis. The higher level of fibrinogen in our study are consistent with Singh et al. And Bao et al. Also suggested that there is a link between the adipose tissue stores and fibrinogen levels. Excess of body fats leads to increased production of fibrinogen are also mentioned by Giordano del. This study found that homozygous and heterozygous CC and CT genotype of RS070 is more common among the obese children as compared to non-obese children in Pakistani population. The relationship between these polymorphisms and childhood obesity are not proven in the previous data. Only the Nicholas et al. In 2016 observed the similar results in hypertensive patients in Greek and British population. So we conclude our study here that expression of fibrinogen was found significantly raised in obese group. The RS070 gene is found to be significantly increased in either homozygous or heterozygous form. The G allele of FGB and C allele of FGA are prevalent alleles in our population. Therefore, we conclude that childhood obesity is associated with hemostatic derangements. Our studies assume importance because elevated fibrinogen have predicted effect on the development of cardiovascular events. We suggest that studies should be conducted to assess the role of genetic and environmental factors in the obesity-related increase in fibrinogen level and their clinical consequence. Thank you.
Thank you, Dr. Ayishah Choudhary. With this, our fourth speaker is Dr. Shabih Haider. He is resident FCPS Hematology in Armed Forces Institute of Pathology. His topic is BCR-ABL1 gene mutation in patients of acute lymphoblastic leukemia.
Bismillahirrahmanirrahim. I am Dr. Mohammad Shabih Haider, FCPS resident in Hematology from Armed Forces Institute of Pathology. And the topic of my presentation is BCR-ABL gene mutation in newly diagnosed acute lymphoblastic leukemia. Acute lymphoblastic leukemia is characterized by presence of over 20% lymphoblast in the bone marrow. It is an aggressive disease, and if untreated, the clinical course is rapidly downhill. The dominant clinical features are usually related to the bone marrow failure caused by the accumulation of the blast cells. Patients present with fever, lymphadenopathy, pallor, hepatosplenomegaly, and occasional bleeding tendency. This is showing the lymphoblast in the patients of acute lymphoblastic leukemia. Coming to the prognostic factors in acute lymphoblastic leukemia, increasing TLC, increasing age, male sex, black ethnicity, massive liver and spleen, testicular enlargement, CNS involvement, Fab type L2, translocation 922, hypoploidy, and time to achieve remission more than 28 days are associated with the unfavorable prognosis. I would be talking about the phylodipsia chromosome occurrence in the acute lymphoblastic leukemia. The phylodipsia chromosome is a translocation that results in the constitutive activation of the BCR-ABL tyrosine kinase. The phylodipsia chromosome positive acute lymphoblastic leukemia is an aggressive disease that responds poorly to the conventional chemotherapy. In both the children and the adolescents, it is placed in the high-risk group. Coming to the BCR-ABL gene translocation, basically it is a 922 translocation which results in the production of phallodipsia chromosome on chromosome number 22. This is showing the cytogenetics of the phallodipsia chromosome. This is showing the molecular genetics of the BCR-ABL. This is the PCR for BCR-ABL which was employed for diagnosis in my case. DNA of variable length was taken, transcription was done, nuclear RNA was formed, RNA processing was done, messenger RNA was formed, then reverse transcriptase enzyme acted and complementary DNA was formed and PCR was done. The following transcripts were obtained, P190 and P210. Now, because of the emergence of the TKI therapy, it has revolutionized the management of phallodipsia positive ALL. Allogenic hematopoietic cell transplantation remains the standard strategy for achieving the long-term disease-free survival. Increasing the number of patients who are unable to undergo the procedure have been treated effectively with regimes combining TKIs with chemotherapy. Now coming to my study, the objective of my study was to study the presence of BCR-ABL gene rearrangement in ALL patients, to establish its association with the clinical hematological parameters, and to assess the clinical response of our cohort. The study design was cross-sectional study. It was carried out at Department of Molecular Hematology, Armed Forces Institute of Pathology, Rawalpindi, between January 2018 and December 2020. Inclusion criteria included all the newly diagnosed patients of acute lymphoblastic leukemia of all the ages and both the genders. All the patients who were already receiving treatment or having secondary leukemia were excluded from the study. Material methods involved the clinical history, the physical examination, complete blood counts, bone marrow examination, biochemical profile, cytogenetics, real-time PCR, and then the follow-up was done. Cytogenetics involved the culturing, harvesting, slide preparation and staining by microscopy, aging, banding, identification of the chromosomes, and then the preparation of the chromosomes. This is the real-time PCR for BCR-ABL1. All patients were studied to real-time PCR multiplex and nested in RNA for fusion of transcripts 190 and 210 at diagnosis according to the International Biomed 1 protocol. Now coming to the data analysis, total sample size was 623. 105 were positive for BCR-ABL1, which is 16.8% of the total population. BCR-ABL transcripts in ALL, now I would categorize who were P190 positive and who were P210 positive. So P190 was positive in 92% patients and P210 was positive in 8% patients. Coming to the age-wise distribution of the patients, in the pediatric age group, 31.5% patients were there. In the adult age group, 50.5% patients were there. And in the elderly, more than 60 years, 23% patients were there. This is showing the gender-wise distribution of the BCR-ABL positive patients. 72% were males and 28% were female patients. Now coming to the clinical parameters, fever, hemorrhage, infections, bone pains, lymph nodes, liver, spleen, and CNS involvement were assessed. Other parameters were similar in BCR-ABL positive ALL and BCR-ABL negative ALL, but the CNS involvement, it was 18.1% in BCR-ABL positive ALL, whereas it was 4.1% in the BCR-ABL negative ALL. So the one clinical feature which was more prominent in the BCR-ABL positive ALL was the CNS involvement. Coming to the hematological parameters, mean TLC was higher in the BCR-ABL positive patients, it was 79, whereas the mean TLC in the BCR negative ALL was 27. Hemoglobin was almost similar. Platelet counts were higher in the BCR-ABL positive ALL. Blasts in the peripheral blood were more in the BCR-ABL negative ALL. Now coming to the post-induction remission in the pediatric age groups, which were less than 12 years of age, 87% were in remission and 13% did not receive remission. Coming to post-induction remission in the adults between 13 to 60 years age group, 64% achieved remission and 36% did not receive remission. Coming to the post-induction remission of more than 60 years patients, 55% achieved remission and 45% were not in remission. Now coming to the discussion, The frequency of BCR-ABL gene in acute lymphoblastic leukemia in our studies is comparable to the international studies. However, it is the first kind of its study in Pakistan in a single center. Hence, there needs to be more research in other centers involved in the diagnosis of acute lymphoblastic leukemia in Pakistan. This is showing a comparison of our study with the international studies. We calculated the frequency of BCR-ABL as 16.8%. A study was conducted in Spain which was showing the frequency as 20%. A study was conducted in Brazil in 2014 which showed the frequency as 34%, and one study was carried out in Italy in 2009 which shows the frequency as 17%. It is a well-known fact that BCR-ABL positive ALL results in poor prognosis. By documenting the incidence of BCR-ABL1 in acute lymphoblastic leukemia patients, oncologists can treat these patients more vigilantly. After a large cohort of patients is studied and meta-analysis of results is done, it may help in the extrapolation of results to the whole Pakistani population. Coming to the conclusion, in our study population, a frequency of 16.8% were BCR-ABL1 positive in acute lymphoblastic leukemia. We recommend that all centers involved in the diagnosis of acute lymphoblastic leukemia should screen for BCR-ABL1 gene as it is associated with poor prognosis. Early documentation will lead to improved treatment outcome and quality of life in these patients. In addition, we reached the following conclusions: that BCR-ABL gene mutation in ALL is more prevalent in the younger age group. Frequency of P190 rearrangement is more common than the P210 BCR-ABL rearrangement. BCR-ABL positive ALL is more prevalent in the males than in the females. BCR-ABL positive ALL tends to be associated with higher TLC count than the BCR negative ALL. And with the increase in the age group, the chances of post-induction remission decreases, and CNS involvement is more common in the BCR-ABL positive acute lymphoblastic leukemia than in the BCR-ABL negative acute lymphoblastic leukemia. I thank you all for patient listening.
Thank you, Dr. Shabih. With this, our speaker is Dr. Anila Ali. She is from Indus Hospital, Karachi, and her topic is frequency of hemoglobinopathies in a tertiary care hospital settings. Over to you, doctor.
Assalamu alaikum. My name is Dr. Anila Aali and I am a resident hematology at Indus Hospital. So my article is on the presentation is on frequency of hemoglobinopathies in a tertiary care hospitals of Karachi. The introduction. As we all know, the hemoglobinopathies are the most common genetically inherited disorders constituting of the structural hemoglobin variant and the thalassemias. According to World Health Organization, 5% of the population are being the carrier for this genetic hemoglobin disorder. Every year, there are almost over 42 million carriers and more than 12,000 infants were born with a major and clinical significant hemoglobinopathies. The worldwide migration, relatively high frequency of consensual marriages in the high frequencies areas have equally contributed for the increased burden of hemoglobinopathy. The structural hemoglobinopathy variant typically are based on the point mutation in a globulin gene that produces a single amino acid substitution in a globulin gene. There are few important subtypes have been identified, out of which the homozygous hemoglobin C and hemoglobin S produces a significant clinical manifestation, whereas hemoglobin E and hemoglobin D homozygotes may be mildly symptomatic. Although the heterozygotes of these variants are typically asymptomatic, but their identification is important for the genetic counseling. Thalassemia, that is a result from the quantitative reduction or absence in the globulin chain synthesis, leading to the life-threatening anemia and requiring a regular blood transfusion for survival. The thalassemia, as we know, that is most prevalent in the Mediterranean region, in Indian subcontinent, Middle East, Africa, Southeast Asia, Southern China, and Pakistan. In these regions, the thalassemia is associated with hypochromic, microcytic, and hemolytic anemias that sporadically affect most of the ethnic groups. Now, the objective of my study is being designed to determine the frequency of hemoglobinopathies and their subtypes in the patient presented in a tertiary care hospital of Karachi. This study will definitely help in formulating the different strategies for effective screening, control, and prevention of hemoglobinopathies. The material and method. This is a retrospective study which is carried out at the Department of Pathology at TIH for the duration of September 2015 to February 2020. A total of 2,422 cases were screened for the presence of thalassemia or any structural variant. The inclusion criteria, we have included the patient with the diagnosis of macrocytic hypochromic anemia with an MCV of less than 80 and MCH of 27 picogram on complete blood count referred for the screening of hemoglobinopathy variant, and exclusion criteria में वो post-transfusion samples are being excluded. A 5 ml intravenous blood sample was collected in EDA anticoagulant test for red blood parameter was done was Sysmex XN100, XN1000 and peripheral smear was stained by Leishman. Results of CBC parameter, peripheral smear examination and nutritional deficiency workup including serum iron profile, vitamin B12, ferritin level and red cell folate was also checked along with the final interpretation of high performance liquid chromatography. Diagnosis of HPLC was done by automatic analyzer ADAMS A1C model number HA8180 Accra Japan, and the grading of macrocytic hypochromia, anisocytosis and polychromasia was done according to the standard criteria. Okay, now the result. This is the age and gender distribution. We can easily say that we have 68% females that are found to have the hemoglobinopathies, and we will go to the age group. We will see the most prevalent are the age group between 15 to 40, and next is 0 to 15 years of age. Among 2,422 total cases studies, normal hemoglobin parameter was found out in 2,070, that is 85.4% cases, and the abnormal fraction of HPLC was observed in 352, that is 14.5%. Out of which the thalassemia syndrome is 76.4% and the variant hemoglobins are 23.6%. If we see in thalassemia syndrome, the most prevalent is the beta thalassemia trait having 57.6% and beta thalassemia major 42.4%. If we go to the variant hemoglobins, the most prevalent is the hemoglobin E and hemoglobin G trait that is count for 27%. Next come to the sickle beta that is 14.4%. And then the sickle cell disease and hemoglobin D disease that is 4.8 and 4.8% respectively. These are the hematological features among the study participants. As we can see easily in the thalassemia major and thalassemia trait, the MCV levels are lower, below that 63 and 68 with the high red cell distribution with and lower HB, that is mean HBs came out with 5.1. In hemoglobin E disease, we can easily see the hemoglobin mean is 5.5 and MCV of 57.8 and the reticular distribution with is 29.5. On HPLC parameter, the HbA2 level is the mean is found in thalassemia minor is above 4.3, and thalassemia major is 3.8. And in hemoglobin S trait, we can see that the S level are the mean is found out to 39. In HBD disease, we have seen the mean of HbD is 74.9. In cases of hemoglobin E trait and hemoglobin E beta disease, the HbE level is around 30.9 and 40.6 respectively. This is the biochemical profile of the study participant. We can easily see it in the patient. The thalassemia major patient, we don't have found any iron deficiencies. The iron binding capacity is not being increased. And the patient which are mostly presented with microcytic and hypochromic anemia usually don't have any hemoglobinopathies. Similarly, the HbE trait patient have the lower iron level as well. The discussion. So the overall frequency of hemoglobinopathies in my study was 14.5%, which is a bit less to a previously presented series of 2,000 cases from a referral laboratory in the region, revealing that 28.2% cases presented. And another study that is reported the finding that thalassemia is the most frequent form of hemoglobinopathies in Pakistan and thalassemia trait is the most common one. And another study that is conducted by Mohammad et al. On distribution pattern of hemoglobinopathies in northern areas of Pakistan, total of 1187 cases of refractory anemia, 25.69% has thalassemia or abnormal hemoglobin. So on the conclusion, to conclude, the heterogeneous population is harboring almost all major hemoglobinopathies in general cases, out of which beta thalassemia is most common, followed by hemoglobin D and hemoglobin E trait, and then sickle cell disease. The RBC indices, HPLC findings, and family studies are sufficient to detect most of the hemoglobin variant in our society. Genetic studies are indicated to confirm the borderline cases and to detect the silent carrier of alpha thalassemia and the rare and novel variants. The present study reflects the magnitude of thalassemia and other variant hemoglobinopathies in a hospital-based population, which may be in fact the tip of an iceberg. The adequate action and screening procedure, especially prenatal diagnosis, should be performed parallel with the aim to lessen the possibility of hemoglobin disorders in offspring. These are some references. Thank you.
Thank you, Dr. Anila Ali. Our next speaker is Dr. Junxia from China. I reckon I pronounce it right. Dr. Junxia did his PhD and MS in genomics at the University of Chinese Academy of Sciences. He joined MGI Application R&D, which is dedicated for the development of new technologies for pre-implantation genetic testing and single cell sequencing. He will be presenting his topic on comprehensive pre-implantation genetic testing by massively parallel sequencing. Over to you, Dr. Junxia.
Thank you. Okay, thanks. I'm honored to have the opportunity to introduce my work here. I worked for MGI Shenzhen for a long period of time. Working at MGI, I was mainly engaged in the development of a new method for pre-implantation genetic testing. So today I will introduce our latest work on PGT. PGT, formerly known as PD and PGS, is a test performed to analyze the DNA from embryos for HLA typing or for determining genetic abnormalities, including the PTTA for detecting the erythroid in embryos, PTM for detecting the monogenic disorder like thalassemia and hemophilia, and the PTSR for detecting the chromosome structural rearrangement in embryos. The method for PGT has been developing for more than 30 years. From fish, we know that STFR-based method and the PCR-based method to array-based method, such as array CGH, SNP array. And then the method moved to evolved to MPS-based method. So BGI is one of the first situation to use the MPS for PGT testing. From 2012, BGI tried to use NGS to detect the chromosome abnormalities in embryos. This study first provides the evaluation of the clinical outcomes of NGS-based PGT-A method and shows the reliability. And also, we want to apply the NGS to detection of PTN. In that time, about 2040, the high depth whole genome sequencing was very expensive. So we developed a method that combined target sequencing and target haplotyping to identify the mutation in IVF embryos. We performed the Sanger sequencing combined with the target haplotyping to evaluate the feasibility of this new method. A family specific haplotype analyzed based on SNP genotyping of the parents and the parental grandmother. According to the SNP genotypings of embryos, we can infer that embryo inherited haplotype 1 of the father was abnormal. Haplotype 2 of the father is abnormal. According to this method, we detect the haplotype of 7 embryos from PKD2 carrier family. The result was 100% accurate and was consistent with Sanger sequencing. And PT is PT of single gene disorder combined with HLA matching can be as a tool to select unaffected embryos of an HLA tissue type compatible with an existing affected child. We did a retrospective study in a beta thalassemia family. We developed a strategy to obtain the full embryonic genome for a beta thalassemia carrier couple to have a healthy second baby. The transferred embryo was collected for more than 30 depths WGS. We diagnosed these transferred embryos as beta thalassemia lective. The genotype of HLA gene has been used before transplantation. For the family, the umbilical cord blood stem cell of the transferred embryos could be used to treat the preborn sisters' thalassemia. We selected the heterozygous genotype of all the HLA gene in NGS data to predict the transmission haplotypes of each embryo. According to the predicted transmission, the haplotypes of the transferred embryo was consistent with the preborn sister. Thus, we determined their HLA types were matched. Until now, high depth WGS is also a little expensive. So, several long depth MPS-based methods, including PTM and PTSR, have been developed. But this method, they also an additional family member, such as a sibling or a proband, is required for PT and haplotyping. So we developed a WGS-based method use medium depth WGS data for comprehensive PGT, includes PTA, PTM, and PTSR. It can detect embryonic balanced translocation and to do parent-only genome-wide PGT haplotyping. This is the workflow. We do the whole genome amplification for embryo biopsies and prepare the libraries, the sequencing them with MGI sequencer. We get more than 17 depth WGS data, and this data will be used to detect the mutation of embryos. WGS-based PT can detect the mutation directly and do haplotyping and the chromosome profiling by the sequencing of whole genome amplified blast-mirror or blast-sister biopsy. It able to enable the parent-only PGTM or PTM with the proband PT structural rearrangements and PT for ploidy analysis. We use carrier mapping and macro-seq with PCR-seq for the validation. SNPs we used for haploanalysis. In informative SNPs in the gene and upstream and the downstream regions of the target gene were analyzed. Figure on right shows the overview of PTM haplotyping with a proband and parent-only haplotyping without additional family members. The left shows the overview of WGS for monogenic disorders haplotyping with a proband. The right is no proband, just parent-only with a reference embryo. We defined the embryo with the heterozygous pathogenic mutation as the reference embryo. For the parent-only haplotyping, we performed the haplotyping based on the number of the SNPs detected for each embryo. M1 for and F1 for defined as the maternal haplotype 1 and the paternal haplotype 1. M2 and F2 were defined as the maternal haplotype 2 and the paternal haplotype 2. And in this study, 10 families was included to as a WGS-based PGT. Along this family, 8 showed genetic risk of monogenetic disease, including autosomal recessive genetic disease, autosomal dominant genetic disease, and sex associated genetic disease. And family 2 and family 1 and family 2 were used for method evaluation. The remaining 2 family showed parental balanced translocation. We use them to evaluate the PTSR performance. Family 1 and family 2 with an average of 17 depth damage data. According to the result of direct detection of pathogenic mutation, 4 embryos of family 1 and 4 embryos of family 2 showed heterozygous mutation. We assessed the graduate depths of embryo data and found that 4 depths of embryo sequence data in lab to credible testing of mutation. We further evaluate the result of WGS haplotyping of the target gene with and without proband using a gradient depth of embryo or family member sequencing data, and found that with more than 4 depths embryo data and 10 depths family member data, the haplotype of the target gene could be determined both with and without a proband. We conclude that the 4 depths of the embryo data and the 10 depths of the parent data were required for the reliable PGT and direct genotyping and haplotyping. And also we evaluate the genome-wide performance of the WGS for the blast-mirs and the blast sisters. We compared the depth and the GC content and the DNA respectively of the genes. We found that the GC content influenced the sequencing depths. The peak of the sequencing depths coincident with 41% of the gene content, and the high or low the GC content, the low was the sequencing depth and the average and the coverage. The depth and the coverage distribution of the genes in each embryo are different. Blast sisters are better than blast mirs. We also evaluate the allele dropout for WGS and the carrier mapping of the embryos. The mean allele for carrier mapping was higher than that for WGS, and the mean allele of the blast mir was higher than that of the blast sisters. We further evaluate the haplotype prediction on a genome-wide scale for both the carrier mapping and the WGS data on family 2 and family 1. Each evaluate 2 embryos. The genome haplotype obtained by WGS was similar, very similar to that obtained by carrier mapping, except for some small segment. Most of them were in telomeres, and some difference were in recombination sites or centromeres. We can see it in its figure. And for the 8 PTM families, WGS haplotyping of each target pathogenic genes with a proband was performed for 40 embryos, and haplotype results were obtained for 100%. Carrier mapping verified all the embryos, and 100% concordance between the WGS and the carrier mapping. WGS enabled direct genotyping of the pathogenic mutation for PGTM. The embryonic pathogenic mutation could be directly tested for 7 out of 8 family with 33 embryos. But not family 3, because the mutation of the DMD could not be distinguished among the noises. ADO was observed for 3 embryos. All of the result of WJ parent-only PTT and haplotyping were 100 concordant with those WJS haplotyping with proband and were validated by carrier mapping. And beyond PTM, we performed the PTA according a previously method we established in 2030. PTA was performed for all the 40 embryos from the 8 families. WJs detected 23 embryos with a normal karyotype. 70 was with erythroid or CMVs. The slip array result verified all the embryos and showed 100 concordance. The figures showed the erythroid result from the embryos with result from the embryos with copy number variation. Then we performed the SPT-SR, uses the embryo with unbalanced translocation as the reference to distinguish between balanced translocation carrier and normal embryos. The PTA CMV breakpoint of the unbalanced reference embryo was identified as the translocation breakpoint. We performed the haplotyping for each embryo using the informative SNPs in 500 kilobase upstream and 500 kilobase downstream of the breakpoint region to determine whether the embryo was a balanced translocation carrier or a normal embryo. PT-SR by WJS were performed for family 8 and family 9 with 30 embryos. The father of the family 8 was carried of balanced translocation between chromosome 5 and chromosome 50.
15. Pardon, Dr. Junzia. We are running short of time, so if you would like to, sum up your presentation.
Okay. Okay.
Thank you.
Okay.
Just read out the conclusion.
Sorry?
Dr. John, just read out the conclusion of the last slide.
Yeah. I will do the summary. And according to the result, doctor choose some embryos to implantation, and according to the among the 8 PTM families, 5 families achieved healthy birth implantation. For family 1 and families family 1 and family 3 are failed. No embryos available for transfer for embryo family 10. Family 8 and family 9 of PTSR achieved the healthy birth embryo transfer. So make a summary. In this study, we developed WJS-based method with 10 depths of family member and 4 depths of embryo sequencing data for comprehensive PT. This method offered a PTM approach for haplotyping without the requirement for additional family members. WJS best, but there are some limitations. The reference embryos was not available owing to failed direct genotyping or an insufficient number of the embryo in some cases. And the GC content possibly influenced the sequencing depth. It may not be possible to detect the embryonic pathogenic mutations in region with too high or too low GC content. But this WS-based comprehensive PET method also provides an improvement complement to the current PET method. And last, I want to say thanks the partners who participated in our study. Okay, thanks.
Thank you so much, Dr. Junzia, and for your precious time. And we are extremely sorry because we were running short of time. Once again, thank you so much. So our next speaker is Dr. Tahir Usman Swati. He is resident FCPS Hematology from Armed Forces Institute of Pathology. And he will present his study on the topic, utilization of new platelet parameters as predictors of glycemic control in diabetes mellitus. Over to you, Dr. Tahir.
Bismillahirrahmanirrahim. I'm Dr. Usman from the Armed Forces Institute of Pathology, and I'll present my study titled Utilization of New Platelet Parameters as Significant Predictors of Glycemic Control in Diabetes Mellitus. Now, diabetes mellitus is a group of metabolic disorders of carbohydrate metabolism in which glucose is underutilized, producing hyperglycemia. It is consistently ranked among the leading causes of morbidity and mortality worldwide. The diagnosis of diabetes mellitus has traditionally relied on the measurement of plasma glucose levels, either in the fasting state or random state, or as a series of tests, serial measurements in the form of an oral glucose tolerance test. In 2011, the American Diabetes Association added a new weapon in the arsenal called glycosylated hemoglobin, or hemoglobin A1C. Now, glycosylated hemoglobin is a very useful test as it requires no preparation. Just a single sample in non-fasting state is sufficient for the diagnosis, and it is reflective of the long-term glycemic control or cumulative glycemic control over a period of 120 days. However, it is not without its own drawbacks. Its measurement is unreliable in anemic patients. There are some measurement interferences by drugs, and its high cost and requirement of expertise limit its widespread availability, particularly in resource-constrained labs. Another point of interest in diabetes is platelet hyperreactivity. Now, recently there's been a lot of interest in abnormal platelet activation, which occurs due to a variety of mechanisms which have been elaborated in this slide. And this platelet hyperreactivity possibly has been implicated in the development of microvascular and macrovascular complications in diabetes mellitus. This abnormal platelet activation is reflected by a change in platelet parameters, and these platelet parameters are widely available even on the most commonly used hematology analyzers. Now, coming over to our study. The objective was to study the association between platelet parameters and glycemic control in patients diagnosed with diabetes mellitus. The rationale was to look for a reliable alternative or a reliable predictor of long-term glycemic control at minimal to no additional cost. The study was conducted at the Department of Hematology in collaboration with the Department of Chemical Pathology at AFIP. It was a cross-sectional study spanning a duration of 3 months with a sample size of 100. 100 type 2 diabetic patients were divided into 2 groups, one with optimal glycemic control while the other was with suboptimal glycemic control. The average age of the first group was 59, while the average age of the second group was 48. Anemic individuals were excluded because of difficulties and unreliability in measurement of hemoglobin A1C, and confounding factors which independently influence the platelet parameters such as thrombocytopenia, thrombocytosis, or ischemic heart disease, stroke, malignancy, etc., patients of these diseases were excluded from our study. 3 ml of venous blood was collected in 2 EDTA tubes. In one sample, platelet parameters were evaluated by automated hematology analyzer, while hemoglobin A1C levels were estimated by capillary electrophoresis in the second sample, and the results were compared using SPSS. Now, this table shows that all the platelet parameters under study had a significant, variable but significant correlation with the level of glycemic control, which shows that they have some value in predicting whether the patients fell in the optimal or suboptimal group. There have been other studies also. The more prominent ones here are mentioned, which have investigated the same phenomena. Our conclusion is that platelet parameters are underutilized markers of long-term glycemic control in diabetes mellitus. And larger prospective cohort studies are needed to correlate these platelet parameters with the specific complications, specific microvascular and macrovascular complications of diabetes mellitus. Thank you very much.
Thank you, Dr. Tahir. Our next speaker is Dr. Sidra Hareem. She is also FCPS resident FCPS hematology from Children's Hospital and Institute of Child Health. She will present her talk on association of blood groups with severity and outcome of COVID-19 infection in children.
Assalamu alaikum. My name is Dr. Sidra Hareem, and the topic of my research presentation is association of the blood groups with severity and outcome of COVID-19 infection in children. The outbreak of coronavirus infection affected both adults and children. COVID-19 is generally a milder disease in children, but severe cases have been reported in the literature. There is differential susceptibility of the patients toward COVID-19 infection in various blood groups, as the human blood type is noted to be a biomarker of susceptibility to COVID-19 infection. The aims and objective of the study was to find out the association of the ABO blood groups with severity and outcome of coronavirus disease in children presenting to a single tertiary care hospital. It was a descriptive study carried out in the Corona Isolation Ward of the Children's Hospital and Institute of Child Health, Lahore, from March 2020 to October 2020. All the patients who were positive on RT-PCR for COVID-19 were included in the study, as well as the patients having multi-system inflammatory syndrome associated with corona disease or Kawasaki-like disease based on antibody test were also the part of the study group. And blood group of all the patients who were available were included in the study. The demographics of the patients were noted. They were classified into different disease severity categories: asymptomatic, mild to moderate, severe, and critical. The disease was also categorized into COVID-19 infection and multi-system inflammatory syndrome associated with corona disease. The underlying comorbid conditions of the patients were also noted. And the outcome was divided into either the patient was discharged, died, or left against the medical advice. Results. Out of 74 patients, the blood group was available in 66 patients, so the study participants were 66. Out of the total population, 32% of the patient had multi-system inflammatory syndrome and 68% had COVID-19 infection. The blood group of the study population, 26% of the patients had A blood group, 35% had B blood group, and 38% had O blood group, while less than 1% patient had AB blood group. So majority of the population was O positive, followed closely by the B blood group. Coming to the Rh status, 94% of the population was Rh positive, while 6% was Rh negative. Coming to age, the mean age of presentation was 7.9 years plus minus 4.1 years, in which 9% were less than 1 years, 18% were between 1 and 5 years, 41% were between 5.1 to 10 years, and 32% were between 10.1 and 15 years. In the gender category, there was no significant difference in continuing the age, there was no significant difference in the mean age of children with COVID-19 and multisystem inflammatory syndrome. But when we come to the gender, in multisystem inflammatory syndrome, the males were significantly higher as compared to female, having 76%, while in COVID-19, the males were 47%. Disease severity, 7% of the patients were asymptomatic, 58% had mild to moderate disease, 27% had severe disease, and 8% had critical disease. So around 60% of the patient had mild to moderate disease. Comorbid conditions like CKD, CLD, CHD, diabetes, surgical causes, immune deficiency, cerebral palsy were also noted in the patients, and 42% of the patients having comorbid conditions had A blood group, 37% had B blood group, 21% had O blood group, and less than 1% had AB blood group. Coming to statistical associations, the patients having blood A group had statistical association with severe disease, having the p-value of 0.030. And they also had statistical significant association with ICU stay and respiratory support. While with disease category, comorbid condition and outcome, there was no statistical significant association. There were 5 deaths reported in our study population, and case fatality rate was 7.6%. Underlying comorbid conditions were significantly associated with a fatal outcome where the p-value was 0.035. And there was no association of the blood groups with the deaths. Conclusion. COVID-19 in children is generally a good outcome. Children with blood group A are more susceptible to severe/critical disease. The presence of an underlying comorbid condition is a risk factor for poor outcome. Recommendations. The people with blood group A may need particularly augmented personal protection to reduce the chances of infection and to receive more cautious surveillance and aggressive management. Limitations. Further research should be done to delineate the biological factor underpinning these findings. Sample size should be more. Anti-A titers also be performed and analyzed in order to determine its protective effect against COVID-19 infection. Thank you.
Thank you, Dr. Sidra. Before we go on to our next speaker, I would request all our speakers to please remain online for the panel discussion and question and answer session. So our next speaker is Dr. Noman Ahmed Chaudhary from Rawalpindi Medical University. And his topic is hematological abnormalities and its relationship with outcome and severity of COVID-19. Over to you, Dr. Noman.
Assalamu alaikum. Am I audible? Hello?
Yes, you are audible.
Bismillahirrahmanirrahim. My name is Dr. Noman Ahmed, and the topic of my presentation today is hematological profile abnormalities and its relationship with severity and outcome of COVID-19 infection. Starting with the introduction, COVID-19 originated first in Wuhan district in China, and it was declared as a pandemic by WHO in March 2020. Since then, it has affected millions of people worldwide, and primarily it is a respiratory disease that resembles virus. Most of the people infected with COVID-19 have mild to moderate symptoms, and they recover after proper medical intervention. And the case fatality rate tends to go higher with the severity of the disease and increasing age of the patients. Typically, hematological profile is one of the first tests requested by the physician in COVID-19 infection, as is the case in most other diseases. And the complete blood count, which also reports differential leukocyte count, can be both a rapid and cost-efficient tool for detection of viral infections. And according to the literature, many hematological abnormalities are associated with COVID-19 infection, and a number of studies have shown that higher total leukocyte count, neutrophilia, lymphocytopenia, and thrombocytopenia are associated with severe COVID-19 infection and worse outcomes. Moving on to materials and methods, our study was a cross-sectional study conducted at the Routledge Institute of Virology and Transplantation, which was declared as a COVID management facility by Rawalpindi Medical University. We included 150 RT-PCR confirmed COVID patients, and for each patient, blood complete picture was ordered at admission, and the report was generated by an automated blood analyzer. Patients were managed according to the national and international guidelines and were followed until recovery and discharge. And various hematological parameters were compared across the age groups, gender, severity, and outcome in terms of in-hospital mortality or discharge. Data was entered and analyzed through statistical package for social sciences (SPSS), and qualitative variables were represented as frequencies and percentages, while quantitative ones were represented as means and standard deviations. Independent samples whose post-value tests were applied for comparing the quantitative variables across the categories of qualitative ones. And we also generated receiver operator curves for detecting the cutoff points of significant hematological parameters, and stepwise multinomial logistic regression was also applied to find the significant predictors of severity and outcome of COVID-19. We categorize the disease into three stages: stable disease, moderate disease, and critical disease. Stable patients included those who had minor symptoms and no imaging evidence of pneumonia on CT or X-ray, and these patients have had fever, respiratory tract symptoms, and pneumonia on imaging. Moderate patients were those who had respiratory distress with a respiratory rate of greater than 30 per minute, mean oxygen saturation of less than 93% in resting state, arterial blood oxygen tension of less than 300 millimeter of mercury, and pulmonary imaging showing more than 50% of lung involvement within 24 to 48 hours. And critical patients included those who had one of the following conditions, like respiratory failure requiring mechanical ventilation, shock, ICU admission for combined multi-organ failure. Results: out of the 150 patients, 43.5 were females, while 56.7 were males, and 54% had no comorbidities, while 46% of the patients had comorbidities. 51.3% had a mild disease, 28% had moderate disease, while 20.7% had critical disease. And in terms of outcomes, 86.7% were discharged and recovered successfully, while 13.3% expired. In terms of severity and relationship of severity and outcomes with demographic profile, we can see here that there was a significant relationship of presence of comorbids with both the severity and outcome, and most of the patients with critical disease had comorbids, and also those patients who died in hospital also had comorbids. Age was also a significant factor in severity and outcome of the disease. Patients having age greater than 65 years of age had critical disease, and similar was the case with the in-hospital mortality. In terms of hematological parameters, we had many significant parameters like total neutrophil count, total leukocyte count, neutrophils, and lymphocyte count. They were significant in critical disease. Patients with critical disease had higher TLC and neutrophil count and a lower lymphocyte count. Similarly, patients with critical disease had thrombocytopenia and significantly lower red blood cell count. They had low values of hematocrit and platelet rate. And similarly, some ratios were also significant, like neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, monocyte to lymphocyte ratio, and neutrophil to monocyte ratio. Patients who had in hospital mortality also had higher levels of TLC and neutrophil count and significantly lower levels of lymphocytes. Platelet count was also significantly lower in patients who had in hospital mortality, and similar was the case with platelet rate. And all the ratios, NLR, MLR, and PLR and NMR were also significant in patients who had in-hospital mortality. The results of logistic regression showed that hemoglobin, neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, monocytes, and presence of comorbids were independent predictors of critical disease and as compared to stable disease. And when comparing critical disease with moderate disease, NLR was also was significant in predicting critical disease. These were the ROC curves constructed. And this is the table showing the details of cutoff points. We can see that highest area under curve was for neutrophil to lymphocyte ratio with an area under curve of 0.917 and sensitivity of 87.1 and 80.7. And the TLC also had satisfactory area under curve of 0.819 and neutrophil count and lymphocyte count were also significant in detecting the critical disease. And we have the cutoff points here. TLC count had a cutoff of 11.29, which means that patients having a TLC count greater than 11.29 had critical disease. And for lymphocyte count, the rate was 7.09, and lymphocyte counts lesser than 1.43 had a critical disease. Similarly, for the outcome, TLC count, neutrophils, and lymphocytes were significant in detecting the in-hospital mortality, and all the ratios were also can also be used for detecting the in-hospital mortality. And highest area under curve was recorded for neutrophil to lymphocyte ratio and monocyte to lymphocyte ratio. Moving on to discussion. Mean age in our study was 65.26 years, and median age in another study was also 65 years, which shows that age is a significant indicator for the severity and mortality of COVID-19. An increased TLC count is associated with an increased severity of systemic inflammatory response as compared to those with normal TLC. Patients with critical disease had higher TLC and neutrophil count and lower lymphocyte count as compared to those with stable and moderate disease. And the results the results of the studies by Liu et al. And Wang et al. In China also confirmed the same results. Several mechanisms have been predicted for lymphocytopenia, and some of those include direct infection and destruction of the lymphocytes by the virus, and destruction of the lymphocytic organs by lymphocytic organs like spleen and thymus by the virus, lymphocyte destruction by the cytokine storm, which includes tumor necrosis factor, interleukin 6 and other pro-inflammatory cytokines, and lymphocyte inhibition due to metabolic side products like lactic acid produced during sepsis. In our disease, patients with critical disease and in-hospital mortality had significantly low levels of RBCs, and patients with critical disease and in-hospital mortality had significantly low levels of platelets also, and this was confirmed by Liu et al. And many other studies. Patients with critical disease also had low levels of hematocrit. In terms of neutrophil to lymphocyte ratio, patients with critical disease and in-hospital mortality had significantly higher levels, which was confirmed by another study. And patients with critical disease and in-hospital mortality also had higher levels of monocyte to neutrophil ratio, and higher levels of platelet to lymphocyte ratio, and higher levels of monocyte to lymphocyte ratio. Our study showed that neutrophil to lymphocyte ratio was the best diagnostic marker for predicting the severity with an area under curve of 0.917, followed by neutrophil count and reciprocal of lymphocyte count, MLR, TLC, and neutrophil to monocyte ratio. In our study, patients who died in hospital had significantly higher median NLR as compared to those who were discharged. In the study by Yan et al., non-survivors also had a higher neutrophil to lymphocyte ratio as compared to those who survived. And similarly, patients who died in hospital had significantly raised platelet to lymphocyte ratio, neutrophil to monocyte ratio, and monocyte to lymphocyte ratio, and hematocrit to platelet ratio as compared to survivors. These new parameters could also be used to predict mortality in patients with COVID-19 infection. We conclude that age and presence of comorbids predict the severity and outcome of COVID-19. Older patients and those with one or more comorbids are more prone to critical illness and are more likely to die in hospital as compared to the young and those without comorbids. Total leukocyte count, neutrophils, lymphocytes, platelets, RBCs, hematocrit, platelet and various ratios like neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, NMR, MLR, and hematocrit to platelet ratio was significantly different between the patients with stable, moderate, and critical disease. And age comorbids, hemoglobin, NLR, PLR, and monocyte count are best predictors for critical illness, while age, PDW, platelet width ratio, and NLR are best predictors of in-hospital mortality. These are the references. Thank you.
Thank you, Dr. Noman. With this, we come to our last presentation, and it will be followed by question and answer session and panel discussion. So our last speaker is Dr. Hamzullah Khan. He is PGR FCPS Hematology in Hyderabad Medical Complex, Peshawar. And his topic is hyperferritinemia as independent risk factor for to predict severity and mortality in COVID-19 infection. Over to you, Dr. Hamzullah.
Bismillah ar-Rahman ar-Rahim. Thank you so much, Mr. Chairman and Mr. Moderator. I am Dr. Hamzullah Khan. I am working as PG resident in Hyderabad Medical Complex, and I will be talking about the COVID hematology and COVID-19, and the topic is hyperferritinemia as independent risk factor and biomarker in COVID-19 to predict the severity and mortality in our hospital. So COVID-19 has left a life-lost impact on the lives of the current era. And the first case was reported in the metropolitan city of Wuhan, China in 31st December 2019, when the WHO declared it as emergency. Since that, by 31st January, the total number of cases exceeded more than 103 million, with 2.2 million deaths around the globe. Regarding the situation analysis of Pakistan, by 31st January, we had 5,44,000 confirmed cases with 11,600 mortality. Similarly, 4,65,000 cases have been recovered, and 1,316 are still under the treatment high dependency units of the country. Regarding our province, Khyber Pakhtunkhwa, we are so far 66,000 cases have been reported and 1,848 deaths so far confirmed. So there was a need to know about the, the factors that can affect the mortality or can predict some severity of the disease. So we usually, in the limited sources centers, they usually focus on the tests that are affordable and done in their units. So we were trying to know about the simple tests and their correlation with the severity and mortality of the disease, starting from a full blood count towards the inflammatory markers like serum ferritin, D-dimer, C-reactive protein, ASR, etc. And we tried to know about their correlations with the disease severity and mortality. So the objectives of the present studies were to know about the role of the deranged serum ferritin level as an independent pathogenic risk factor to predict the progression of a disease towards a worse outcome in our setup. This was a cross-sectional study as was done from 1st March to 20th August 2020, and PGMI HMC Peshawar. Total 320 patients were selected. Out of those, 267 were COVID-19 confirmed cases. The sample size was calculated from the assumptions of the study as shown. We put the reference ranges of the serum ferritin as low less than 15, borderlines 16 to 14, and high more than 400 is defined by the WHO in many studies. In this present studies, we defined our variables. These were numerical and categorical variables, and we applied some correlation tests to know about the correlation of the quantitative variables with the severity and mortality of the disease. Similarly, for prediction of the mortality and worse outcome, we use binary logistic regressions. And for the diagnostic role of the serum ferritin, we used ROC curve. Similarly, for the purpose of mortality and the groups and the gender groups, we used Kaplan-Meier test to know about the probability of mortality due to COVID-19 under the influence of high level of ferritin in our patients. So this is the gender and age distribution. About 73.78% of our population were male, comprising of male gender with 26% female. majority of our patients were in the age range of 36 to 55 years, followed by more than 55 years age. The normality of the data was calculated using Sheffer-Well test, and it shows that the ferritin distribution in our patients was not normally distributed while the age of the patient was distributed normally. This shows the area, the ROC curve, to show some the values, the diagnostic values of some of the hematological markers in COVID-19. If we see here against the neutrophil to lymphocyte ratio, NLR was having more than the area under curve for NLR was 0.67, followed by ANC and platelets, and the other markers were not significantly diagnostic for this purpose, as we take the benchmark of 0.5 for AUC. This is the AUC curve of serum ferritin with the area under curve 0.67, with sensitivity of 90.5%, with specificity 78.25%. We compared this sensitivity and this AUC with standard PCR. So this is the comparison of the serum ferritin with PCR. These are the area under curve of various hematological and inflammatory markers that we study in this present study. If we see the ferritin, the area under curve was 0.7, followed by the NLR, that is 0.67, and absolute neutrophilic count, that is 0.6, and the rest of the markers, these were not significantly comes under the AUC. This is shows the quantitative correlation of the deranged serum ferritin level with age and hospital stay. If we see, there was a significantly correlation of serum ferritin level with age. When the age increases, usually the serum ferritin level increases, and it shows the severity and a high prediction of high level of mortality in this patient. Similarly, if the hospital stay increases, there is an inverse relations with serum ferritin level, because these are usually in these patients the mortality usually occurs. And again, if we see the hospital stay, that has a direct relation with the age of the patient. If the age of the patient is more, that is a direct relation. Usually they have more, they are supposed to be kept under treatment for more hospital stay. This is the quantitative correlation of serum ferritin with the age. If we see usually in the age 40 to 60, the higher level of ferritin were observed. And these were the patients that had some severe disease outcome in terms of mortality. This is the Kaplan-Meier test that we used to know to predict the severity of the disease under the influence of deranged ferritin levels in gender groups. If we see the female gender that offers more protection as compared to the male gender, even at the age of more than 80 years, there is 65% chances probability that they will survive under the with high ferritin levels as compared to the male gender, where if we see at the age of 80 years, their survival drops vertically almost 45 to 25% as compared to the female gender. So the female gender offers more protection and more immunity as compared to the male gender. And there are more reasons and more explanation to this. Some of the scientists usually they have reported that the female gender, they usually produces a high titer of COVID antibodies as compared to the male gender in early infections. So if we compare our diagnostic values of our ferritin with other studies, so usually the other studies that mostly of them are reported from the China, that reported the first cases of the COVID. So usually our AUC curve, they usually matches in terms of AUC sensitivity and specificity with other international studies. Similarly, we used binary logistic regression to know predict the odds ratio and the probability of severity of the disease and mortality. So if we see, there was 1.8 times the patients that had deranged levels, that are high level of ferritin, they had 1.8 times more chances to meet the worst outcome in terms of death as compared to the patients who had normal level of ferritin. Similarly, if we compare our finding with other international and national studies, one of the retrospective studies that is reported from the Karachi main hospital, Aga Khan and Liaquat National Hospital, usually the findings, they reported the hemoglobin also as a prognostic, but we did not find some difference in those as compared to the PCR. Similarly, their findings were in concordance with our study in terms of TLC, ANC, NLR, and platelets. Usually these patients had thrombocytopenia, an increased level of TLC, ANC, and low platelets, low ALC. NLR and ferritin was also, in the lower slide, ferritin was also significantly correlated with these studies. So in conclusions, hyperferritinemia, we observed that 80% of our cohort patient had deranged level, that is more than 400 microgram per liter of ferritin. The diagnostic value of the ferritin as compared to the standard PCR, that was the area under curve for ferritin was 0.7, that was significant. So it means that we can use, if we don't have the facility of PCR or rapid antigen test, so we can take the help of the understand the severity of the disease with the values of serum ferritin. Similarly, it has a prognostic value, and there was a significant difference in the serum ferritin level among the survivor versus non-survivor in our study. Similarly, regarding the correlation, that is, there was a statistical uphill positive correlation of the serum ferritin level with the age of the patient, and as well as with the outcome in terms of death and hospital stay. And finally, and least but not the last, usually we find that there was a survival benefit of those patients who had a low ferritin level. Similarly, the female gender was more reported to be more protective with more survival with deranged serum ferritin level in all age groups as compared to the male gender. So, and finally, this study was recently accepted in a national journal, that is Professional Medical Journal. Thank you so much.
Thank you so much, Dr. Hamzullah. And with this, we come to end of our presentation sections. And now it's open for the panel discussion and the question and answer session. We have received two questions. One is for Dr. Tahir Usman Swati, and the other question is from for Dr. Sidra Hareem. So the first question that we have received from the attendees is from Dr. Fazle Rahim. He is a pathologist from Timargara, and he has asked a question that in your presentation, platelet parameters are not discussed for glycemic control. Yes, Dr. Usman.
Thank you very much, sir, for the question. Sir, to summarize, the four parameters which we studied were platelet large cell ratio, mean platelet volume, platelet rate, and platelet distribution width. And when we compared these parameters against glycosylated hemoglobin levels, we found that all the parameters, every single one of them, was significantly predictive of whether the patient had optimal or suboptimal glycemic control. The most closely associated was the mean platelet volume, followed by the others. So we are highlighting that these four parameters, all of them, especially mean platelet volume, is a somewhat neglected marker of long-term glycemic control and possibly of micro and macrovascular complications in diabetic patients.
Thank you, Dr. Tahir.
If anyone, Dr. Ayishah or Professor Lubna, they want to, the very interesting study in a way that by studying the genomic sequencing. Now, as he mentioned the monogenic disorder, most importantly thalassemia. Now, my question might be that is there any likelihood that this methodology in one way can replace the prenatal diagnosis, CVS sampling? That's what I want to ask. If anybody, you can, if there's any chances that if it can replace the CVS sampling?
Can I respond to
yes,
you?
Yes, please, ma'am.
What I could check here is ये IVF के ऊपर इन्होंने वो किए हैं जैसे स्टडी किया IVF के लिए तो हमारा तो इतना I don't think कि हमारा ये वाला aspect of अभी तो CVS को establish करने लगे तो pre-implantation lab होना जरूरी होगी before you can go to this.
So where there is a facility of
I think और फिर उनका थोड़ा एक उसमें ये भी था कि exonic जो है mutations जो कि हमारी बीटा mutation ज़्यादा एट्रॉनिक रीजन थे उनको शायद इतना आइडेंटिफाई क्लियरली नहीं कर पाए. This is what I could get.
So where there are the in vitro fertilization labs, where we can utilize this facility for the early diagnosis?
So, but I can say with all my knowledge here in Pakistan, I think in vitro lab, second उसका molecular lab के ऊपर काम करना और then this study would be. क्योंकि truly 2021 की कोई study है जो कि as you know Chinese का तो ज़्यादा आगे ही है molecular genetics. अगर आप मुझे सुन सकते हैं तो I just want to make one comment, a German comment. The young budding scientists, mashallah, all the young fellows, their teams and their supervisors, they have contributed with good topics, good presentation, well timed mostly, और बहुत अच्छा सेशन था, बहुत अच्छे टॉपिक्स सुनने को मिले और we wish कि इन्हीं स्टडीज को इन्हीं टॉपिक्स को जरा elaborate level पे किया जाए as COVID-19 has given lot many avenues for hematologists to work on because the pathogenicity was convulsive. तो बहुत से parameters lymphopenia और तो इस लिहाज से हमारे young scientists ने data generate किया है local, which is very encouraging. I am really impressed by all the presentations. Well done, residents and their team. Thank you.
Thank you, ma'am.
Questions वगैरह कुछ हैं या
Yes, we have one question for Dr. Sidra Hareem, and the question is from Dr. Mohammad Chaudhary, Sahara Medical College, Norwal, and his question is that in your study, blood group A appears to be more vulnerable in children. Is there any relationship with subgroups of blood group A? Dr. Sidra.
Assalamu alaikum. Sorry, the study was limited. The subgroups were not evaluated. So we only did the group A. We didn't perform the subgrouping of group A.
Thank you, Dr. Sidra. Sir, ma'am, any comments or any more questions?
Yes. I think we would like to wind up this session. First of all, I would like to thank the organizers for giving us this opportunity to be part of PSH in a very important session. And I and my colleague Dr. Nadeem and Ayishah, we are actually grateful to PSH organizers. We must congratulate the PSH team, especially the president and Dr. Nuzhat especially, who have actually done a marvelous job in this very challenging time with this COVID pandemic going on, and holding a virtual conference with such expertise and ease, and it being so well attended and appreciated, I think speaks highly of their effort and hard work. Coming back to the presentations, we actually had a very relevant topics. They were discussed by our junior colleagues, and it is encouraging that over a period of time, the speakers, they have prepared well, and they have selected very relevant and nice topics which we all could relate with, and at the time they are need of the moment actually. And most of the speakers, they stuck to time and they were well prepared, and I must appreciate their effort. And especially seeing this young house officer who actually came up with these hematological parameters. So it is very encouraging that people are actually taking to research in our resource constrained setups. And then finally, this the Chinese study. It is obviously it's a very futuristic thing at present, but then the way things are moving, the genetic diagnosis, the way it is taking hold of lab workups. So we are very positive and very hopeful that soon it will be also available in Pakistan with the help of our Chinese these researchers and collaborators. So in the end, I would like to congratulate the whole team and thank the effort of the whole team of PSH who have organized such a wonderful event. Thank you very much.
Thank you so much, ma'am. Thank you so much, sir. It was a real pleasure and honor to have you as our panelist, ma'am. It was a real pleasure to have renowned and distinguished hematologist as our panelist. And we are thankful to our speakers as well. They prepared very well and they presented very nice and wonderful presentation. Thank you so much. With this, we come to an end, and goodbye for now.